Welcome everyone. So now we will be studying preeclampsia. As the word pre includes means before, eclampsia means condition in which there is raised blood pressure, proteinuria, and different clinical pathologies. So that is preeclampsia. Now preeclampsia is a condition which is characterized by hypertension at least 140 by 90 millimeter of mercury, recorded on two separate occasions at least uh, first hours apart. So it occurs in the pregnancy, and along with hypertension, there is proteinuria and edema on the legs of the patient, resolves completely by sixth week of postpartum. Now, risk factors. What are the risk factors for preeclampsia? Risk factors includes first time pregnancy, multiparous women with previous history of preeclampsia in any previous pregnancy are greater than 10 years since last baby. These patients can develop preeclampsia having age greater than 40. BMI is increased means obese women are more prone to develop preeclampsia, and booking diastolic blood pressure is greater than 80. Proteinuria is there. Proteinuria is greater than 3. Pre-existing medical conditions like hypertension, renal failure, and diabetes mellitus. So these females are more prone to develop preeclampsia. These are the risk factors for preeclampsia. So in this way, preeclampsia develops, and the pathophysiology behind preeclampsia is uh, stages of the preeclampsia. In first stage, there is deficient trophoblastic invasion occurs. In preeclampsia, there is failure of trophoblastic invasion in the myometrium and segmental spiral arteries. Due to deficient trophoblastic invasion, arteries spiral arteries supply intervillous space cannot transform into large sinusoidal vessels. So these changes don't allow normal transformation of the vascular supply, and to a low blood pressure and high flow system, resulting in inadequate blood perfusion to the placenta, and there is a uteroplacental ischemia of the baby can occur. So this is the pathophysiology behind preeclampsia, and that's why it is dangerous for baby as well. Second stage, characterized by endothelial dysfunction and diffuse vasospasm occurs, and it is because of endothelial damage and diffuse vasospasm. There results into increased peripheral vascular resistance, and which leads to renin-angiotensin activation and accumulation of the fluid and edema. With vasospasm due to reduced perfusion and organ damage can also be there, and that's why proteinuria occurs, because kidneys are damaged because of ischemia or decrease and organ perfusion. Endothelial damage results into increased capillary permeability. It results into development of edema on the feet, and organ specific damage includes cardiovascular system, increased peripheral resistance causing hypertension, increased capillary permeability leads to hemoconcentration and edema. Hematological changes results into coagulopathy, means because increased fibrin and decreased platelets, and hemoconcentration due to decreased plasma volume. Renal changes are also observed, like proteinuria occurs, excretion of the protein in the urine, and decreased plasma oncotic pressure, and worsening edema occurs in the patient, and glomeruloendotheliosis also observed in these patients. So in this way, protein preeclampsia is present. Now, clinical features of preeclampsia includes symptomatic features like frontal headache, visual disturbance, and epigastric pain will be complained by the patient. Patient may complain flu-like illness, and a headache will be there, suggesting CNS involvement, epigastric pain because of liver involvement, increase LFT, AST. Visual symptoms include retinal arteriolar spasm like photopsia, flashing of the light will be complained by the patient, scotoma, dark areas in the visual spot will be there, blurred vision, and diplopia are the prime factors which are indicating that patient have developed preeclampsia. Signs are the elevated blood pressure, increased blood pressure 140 by 90, worsening edema on the feet will be there, and brisk reflexes will be there. Ankle clonus will be positive, and uterus and fetus are the small for gestational age because of inadequate blood supply to the baby. And investigations for this disease will require regular monitoring of the blood pressure, and if proteinuria has developed, then urine lysis, dipstick test, 24-hour urine collection, and random protein creatinine ratio will show these values in lab test, and complete blood count should be assessed in order to look at the profile of the blood and coagulation profile should be looked at, and the renal function test, liver function test are mandatory. Plasma urate concentration for uric acid level, and assessment of fetal well-being. Ultrasound and amniotic fluid volume should be assessed regularly in order to ensure the safety of fetus. So if patient has developed this condition, so how can we manage the patient? Management requires admit the patient to the hospital, monitor blood pressure 4 times a day, routinely testing proteinuria quantification is not recommended, while monitoring CBC, LFT, and renal function and electrolyte twice a week is mandatory. Blood pressure should be managed by oral labetalol drug is the drug of choice, and targeted blood pressure can be for less than 150 millimeter mercury. So in this way we manage the patient mainly by giving oral labetalol and other symptomatic complication treatment. So in this way we manage the patient of preeclampsia. So we discussed preeclampsia. It is condition in which blood pressure is increased and it is about 140 to 90 millimeter of mercury. Systolic and diastolic pressure which characterized by end organ damage. Kidneys are more prone to be damaged in preeclampsia, and that's why lethal edema is developed, and we treat with oral labetalol uh, by this patient. So in this way we can manage the patient of preeclampsia.